Dr. Emmenegger is a medical oncologist at Odette Cancer Center, Division of Medical Oncology, and he is associate scientist at the Sunnybrook Research Institute in the Biological Sciences platform. Both these are at Sunnybrook Health Sciences Center in Toronto. He is also associate professor in the Department of Medicine and associate member of the Institute of Medical Science, both at the University of Toronto. Dr. Emmenegger obtained his medical degree from the University of Bern in Switzerland in 1992. Following this, he trained in experimental medicine and biology, internal medicine, and medical oncology in Switzerland. In 2001, Dr. Emmenegger joined the laboratory of Dr. Robert S. Kerbel at Sunnybrook Research Institute to undertake postdoc training in tumor biology until 2008. His special emphasis was on tumor angiogenesis, metronomic chemotherapy. In addition, he completed a clinical fellowship in genitourinary medical oncology at the University of Toronto from 2005 to 2008. Dr. Emmenegger is specialized in the systemic treatment of advanced prostate cancer. Aside from industry-sponsored clinical trial activities, he is interested in optimizing the real-world care of men with advanced prostate cancer, including the management of bone metastasis and bone health, the study of treatment-induced sarcopenia, the characterizing of relevant drug-drug interactions between novel prostate cancer medications and other medications frequently used by prostate cancer patients, and the combined use of stereotactic ablative body radiotherapy with systemic treatments. And in case you're wondering, I'm sure Dr. Emmenegger knows someone who knows someone who knows someone, in case you want to know, in case you want to meet Roger Federer. So I'm sure he can help. Can you, Doctor?
No connections to Mr. Federer, unfortunately.
Oh, unfortunately. No problem. So without any further ado, I'll give you Dr. Emmenegger. His topic for today is treatment of advanced prostate cancer from A to Z, and the A is for palutamide and the Z is for ytiga. Dr. Emmenegger.
I was asked to start with a little bit of an introduction about myself as a person, and I have a few slides prepared, so I will not start with prostate cancer first. This is a slide for where I'm coming from. I was born in a small village of 3,500 people in the center of Switzerland. And when you see here on the arrow here, this is actually where I spent most of my 21st years of my life. And at the time when we went to school, we actually went to school in the morning, we came back home for lunch, we went back to school again, 1 kilometer each way. So we were walking 4 kilometers each day, whether raining or snowing. And you will see why this is of a certain importance for what I show about my hobbies. When it comes to the question about why I chose to become an oncologist or a physician, more specifically, I had at some point a choice to make between becoming a musician, and my instrument was the trumpet, and becoming a physician. It's actually hard to say why I decided one way or the other, but I'm happy with my choice. The question why I became a prostate cancer doctor is really more difficult to answer, because that was probably more driven by having an opportunity here at the Odette Cancer Center to do this fellowship. During my training, I had seen not more than 3 prostate cancer patients. And when I did the fellowship, I was allowed to specialize within all the malignancies that affect the genitourinary tract, to specialize in prostate cancer. And since then, I haven't really looked back. Now, the reason why I came to Canada is in certain ways simple, in certain ways not so simple. I was looking for doing some research, and I had the opportunities to go to San Francisco, to go to New York, or to go to Toronto. And in hindsight, it was a great thing to come to Toronto, because we moved to Toronto just after September 11th, 2001. And one of the reasons why we came to Canada, not the United States, was the fact that my wife really didn't like George Bush. And who would have thought that we now think as George Bush as one of the maybe not so bad presidents of the more recent past. And the second thing was that when I had interviews for my postdoc position, we spent some time in Yosemite National Park in California. It was really nice weather. And when we came into the Bay Area, it was foggy, it was windy, it was cold. Again, my wife just told me that she did not want to go to San Francisco. So sometimes non-medical and non-scientific reasons are more important for certain decisions. What do I miss in Toronto? Sometimes a bit food items. I still think that the cheese I can get at home with my parents tastes better than the cheese you can buy here. And my favorite hobby is running. I usually was running 1 marathon per year, including this marathon here in Switzerland in 2018, where you run a marathon up the mountains. And I tried that again in a year later, but unfortunately I came back with stitches, with a blue eye, and also a little bit of bruised ego as well. But despite some of my accidents, and some patients have seen me with my bruises, I still like running, although at the moment with the winter it's not so great, and then with COVID-19 neither. In terms of music, my kids, they like rap music. I have, from a completely different angle, I think that Johann Sebastian Bach is probably the best composer ever. And if I need some downtime, I usually listen to Bach music. And finally, something North American in terms of TV shows, I really like Seinfeld. It's a show about nothing, but it's actually always about anything. And I'm famous at home to cite Seinfeld episodes when it comes to explaining some certain things to my teenage boys. And maybe the last slide about myself, what is on my bucket list? I really would like to go at some point to the Himalayas. I hope that when I'm retiring that I'm fit enough to do that. This is really then going into high altitude. I don't have any aspirations to climb Mount Everest, but to be at the base camp of Mount Everest probably would be a great experience. So let me then maybe start now with the first slide here, just to show you that I do a lot of clinical studies, and obviously I deal with companies. I think companies are important. We often see companies as entities that try to influence physicians in prescribing certain drugs. I see the positive aspect of working in companies. Doing clinical trials offers patients access to medications. Canada is at the forefront of many clinical trials in prostate cancer, and often gets medications approved earlier, and they are marketed earlier than in other places. So for Canada, actually being a country with a very active trial portfolio has been very beneficial. And before I start to speak about specifically some prostate cancer issues, I would like to start with this slide here. I might use sometimes numbers. I might also sometimes speak about prognosis, but please be reminded that each patient is different. Each patient has a different prognosis. Prostate cancer comes in many, many different flavors. And whatever I tell you probably does not apply to your situation specifically. Should I mention anything that bothers you, then please let me know. I'm happy to explain in more detail maybe how this might apply to your situation. What I would like to do is that I would like to tell you what I understand with the term advanced prostate cancer, and then speak about the treatment options that we have. And in fact, we have 10 treatment options that we know can not only make patients live longer, but they can also improve the quality of life of patients with prostate cancer. I will speak about some treatments that are just about to become available in Canada. And then at the end, I also have one slide about COVID-19 and how COVID-19 factors into some of the treatment decisions currently. And I want to start with the definition of advanced prostate cancer. When you take 100 Canadian men that are diagnosed with prostate cancer, around 10% of these patients will already have metastases, spread of the cancer to other organs when they are diagnosed with prostate cancer. And this is a group of patients that we call metastatic castration-sensitive prostate cancer. So these are patients that never had a treatment for prostate cancer before. And you see they have a number of treatment options, which I have listed here alphabetically, because really we do not really know which treatment is better than the others. We actually assume that these treatments are equivalent, and we just have to find the right treatment for the right patients. 90% of patients with prostate cancer will have prostate cancer that is confined to the prostate gland. And they have, in essence, 3 different treatment options. Either they go into a program where the cancer will be let in place, but they will have repeat PSA measurements. They will have maybe a repeat biopsy from time to time. They might have MRI scans. And in essence, it's to find out whether a cancer that is considered being not harmful at the moment changes over time, which then can trigger to actually undergo some treatment. But many men will undergo what we call active surveillance for years and might never need any radiation therapy or any surgery. And radiation therapy and surgery are the key tools for patients with localized prostate cancer. And radiation therapy in certain under certain circumstances are combined with what we call ADT or androgen deprivation therapy to optimize the outcomes. But we also know that unfortunately, of all the patients with localized prostate cancer, around 1 out of 4, 1 out of 5 eventually will have a rising PSA. The rising PSA can mean that there might be some cancer cells around. Often we can't see them on the scans, but we know they are around. And if they are in other organs, then this unfortunately is the first sign that the cancer has become incurable. Or sometimes it's just prostate cancer growing back at the place where everything started, and these patients have the option, for instance, to do radiation therapy. Sometimes they can also do surgery. And some of these men can still be cured despite the rising PSA. But eventually, with a rising PSA, many men will start androgen deprivation therapy. And then they at some point will transition into a phase where they will have metastases. And in this case, then the metastases are no longer really responsive to androgen deprivation therapy alone. Or in some patients, they will have a rising PSA. They start androgen deprivation therapy, the PSA comes down and then it starts to rise again, but we can't find any metastases on the scans. And these patients have non-metastatic CRPC. So when I speak about advanced prostate cancer, I really mean patients with metastatic prostate cancer or patients with non-metastatic prostate cancer, but having cells that are resistant to androgen deprivation therapy alone. And we know that unfortunately, all these 3 stages that are highlighted here in yellow boxes are stages where we know that we can keep the cancer under control, but we can't get rid of it indefinitely. Now, often patients and family ask me when they come to see me whether they have stage 4 prostate cancer or not. And I actually don't like the term too much, because stage 4 cancer often is associated with being somehow close to dying and only having maybe sometimes a few weeks or a few months. And this is definitely not the case for prostate cancer. Stage 4 prostate cancer, in essence, means that the cancer spread to other organs. And I had recently one of my patients who died 18 months ago. He was diagnosed in 1993 with a documented metastasis to one of his pelvic bones. So patients with stage 4 prostate cancer can live for years and years and years, but unfortunately, there's also patients that might actually not do so well. And there's a few things that we can do to get a better idea about maybe what the prognosis is of patients overall. And probably the most commonly used is the Gleason scoring system. That is a system that was developed by a pathologist called Donald Gleason in 1966. And what it's based on is that prostate cancer grows in different versions, in more or less aggressive versions. And the higher the number is, the more aggressive the growth pattern is, and the more aggressive the cancer will behave. And when a pathologist reads a prostate biopsy, they will assign the first and the second most common growth pattern, and will then add these 2 numbers. So if a patient, for instance, has 60% Gleason 4 cancer and has 30% Gleason 3 cancer, this will add up to a Gleason score of 7. and 10 are the most aggressive cancers, and Gleason score of 6 are cancers that these days we often would not touch and just leave in place and would do active surveillance, as I told you before. Aside from the Gleason score, the amount of tumor cells matters as well. And you see here a bone scan. And obviously, there's no need to explain that this is a patient that has a widespread bone metastasis. All the black dots on the left side of the panel you can see in the ribs, in the spine, represent places where there's cancer cells. With the only exception, the really big black spot here down here, this is the bladder. This is normal. The bladder actually turns blackish when you do a bone scan. But this patient definitely has a very high tumor burden. And the higher tumor burden is usually a little bit more compromised the prognosis might be. And something that is unique to prostate cancer is that prostate cancer is a disease that is really driven by the androgen receptor. The androgen receptor is a molecule that can bind male hormones, in particular testosterone or dihydrotestosterone, which is a biologically very active version of testosterone. Once testosterone binds to the androgen receptor then moves into the nucleus of the cell and starts a program to produce proteins. And one of the proteins that is produced under control of the androgen receptor is PSA. So this is why we do so much PSA testing. Whenever the PSA goes up, this means that we have active androgen receptor with very few exceptions. And that's a sign that we might need to reconsider the treatment and bring down the PSA again. Now, in the next few slides, I will speak in relatively broad terms about some of the treatment options we have. And I did not really make a lot of slides to compare these treatments to each other, but just to give you some good idea about what it means also in terms of practicalities. And I want to start with androgen deprivation therapy. This is a treatment that was first found to be helpful in 1941 by Charles Huggins, a physician from Nova Scotia who worked during his academic career in Chicago. And he was really the first to realize that if you can reduce the concentration of circulating male hormones, in particular testosterone, and then you can have a positive impact on men with prostate cancer. And this resulted for him in a Nobel Prize in 1966. So 1966 is the year where Charles Huggins got the Nobel Prize, and is the year where the Gleason score was for the first time published. And initially, hormone treatment, as we call it often when we're in the clinic, and in essence, this is a form of castration, was done surgically by just removing the testes. And in the 1960s, there were some studies done with using female hormones as a replacement for the surgery, but female hormones have quite a bit of side effects, including an increased risk of blood clots. And this is why this was eventually then given up. But most of you know these agents here, Soladex, Eligard, Lupron, and so on. And we call it hormone therapy, but in essence, it's a anti-hormone therapy, so to say. And the difference between these drugs is more in practical terms. Some of them are injected into the tummy, some of them are injected into the buttocks, some of them can be injected every 3 months, 4 months, 6 months. So it is more about the practicalities than we can really say that one drug is better than the other. And what these agents do is that they block the communication between the pituitary gland in the brain and the testes. And in essence, they freeze or silence the testes. And the testes are the source of around 95% of male hormones. And thus, if you start these treatments, you can really drastically reduce the concentration of male hormones, which makes it very difficult for prostate cancer cells to grow and proliferate. This is a treatment that works in the majority of patients. It's very rare to see patients that don't have a response at all, but as many of you know, these treatments also come with side effects, and I do not want to discuss that here in detail. This is something that you definitely will discuss with your physician from time to time. But overall, this is probably one of the most successful treatments in oncology when you consider the high response rate, the duration of responses, which is counted in years. And yes, there are side effects, but we also have become better, I think, in the last few years to deal with many of these side effects. One thing that might change relatively soon is that thus far we didn't have any tablets that could have replaced injections. And I have a few patients that really don't like just to see needles and even more so to be poked for the hormone injection. There is a medication that was recently approved in the United States and probably will become available in Canada relatively soon as well, called relugolix. This is a tablet that can somehow do the same as the hormone injections. It actually might work even a little bit better than the hormone injections in terms of bringing down the testosterone levels, but whether this really results in better outcome of patients, we do not yet know. And it works more rapidly at the beginning, brings down the hormone levels more rapidly. And once you stop it, it takes not as long before the hormone levels start to rise. So this is something that might give us a new tool that definitely might have some benefits in certain situations. Obviously, the big disadvantage is that you need to take these tablets on a daily basis, because otherwise they do not do a good job. And the benefit of the injections is that if you do it every 3 or 4 months, you don't have to think each day about taking the tablets. And one potential benefit of these tablets is also that they might be more safe when it comes to what we call cardiovascular side effects. These can be heart attacks, can be strokes. And in particular, patients that already have heart conditions that, for instance, had a heart attack before, they have a relatively high risk of having another heart attack or a cardiac complication in the first 6 to 12 months when they go on hormone therapy. And this risk seems to be lower in patients that take the tablets as opposed to patients that are treated with leuprolide, which is the drug that is used under the brand name of Lupron or ytiga. So hormone therapy is really the basis of all treatments. And I will assume that in Canada, there's probably almost no man with prostate cancer that has spread to other parts of the body that never will get any type of hormone therapy. And as I mentioned before, it has a very high response rate and overall relatively manageable side effect profile. But really, for men where containing the prostate cancer is important, we need different tools. And the job of an oncologist like myself is to use as many of these tools in the safest way possible. And in prostate cancer, typically we don't mix too many things together. We do one treatment after the other. And which treatment you use first, second, and so on depends really on the cancer stage, whether there's a high tumor burden, low tumor burden. Sometimes depends a bit on where the metastases are. It makes a difference whether patients have metastases in the bones, which is the most common hiding place for metastases, or whether it's, for instance, in the liver. It also depends on what type of treatments patients had before. We often try to switch from drugs that work in certain ways to drugs that work in a different way. It's in Canada not that much driven by drug access, because we have relatively liberal access to most medications, at least when you're 65. And I can't really understand why men below 65 have a higher threshold of getting access to a certain medication. That doesn't make sense to me, but unfortunately is the case. And I do not think it will change anytime soon. Then it might also matter what type of other health conditions patients have. For instance, when it comes to chemotherapy, having a lot of other health conditions might be rather reason not to consider chemotherapy, but that also applies to some of the other medications as well. And eventually, I think patients have the choice, and it's really up to me as a prescribing physician to explain patients the pros and cons of certain medications and give them all the options. Now, we know that all these treatments, they work for a given time, and that sometimes we have to switch typically to another treatment. And there's different reasons why we switch to another treatment. The most really, the strongest reason is if patients have symptoms. So if a patient, for instance, has prostate cancer that has spread to the bones, starts to have pain, then we usually don't wait too long before we start the new treatment. We are also more concerned in patients where we see changes when we do scans. So if, for instance, all of a sudden we not only have 10 spots in the bones, but we have maybe 50 spots in the bones. And with respect to the PSA is useful, but small changes in PSA, slow increases typically are not really a good reason to change a treatment, because often you can keep patients on certain treatments for months beyond the point where the PSA started to increase. In our place, we have a lot of clinical trials open. As I mentioned before, a little bit when it comes to interactions with pharma, trials offer patients extra treatment options that might not so rapidly become available outside of a clinical study. And I have a lot of patients that at least once or twice will be part of a clinical study. But what we also have learned is that mixing things together and doing too many things at the same time might not always be better. And we learned that particularly when it comes to chemotherapy, docetaxel chemotherapy, which is the most common chemotherapy we use, it's typically given on its own. There were 9 large studies where docetaxel was combined with something else, and none of these studies actually improved the outcome over using docetaxel alone. But overall, I would say that most patients are fit enough to not just get hormone therapy, but at some point also to get one of the other medications that I will just discuss now in the next few slides. And if you have any questions about medications, this is a site here from Cancer Care Ontario, which really provides good materials to read about the most commonly used prostate cancer drugs. And these are also the materials that I usually provide to my patients when I start them on a new treatment. So why do we, for instance, use medications that interfere with the androgen receptor when they already are resistant to the hormone injections? What we know is that once we can silence the testes, the cancer cells have other ways to get access to testosterone, other androgens. Either they can use some weak androgens that are produced in the adrenal glands and can convert them into testosterone, or some cancer cells actually can start to produce testosterone on their own. And these are sources of testosterone that you can't block with the hormone injections. This explains why some of the most powerful drugs we have are drugs that were introduced just in the last 10 years, and they work in different ways. Abiraterone is a medication that blocks the production of male hormones in general. That works in principle in the testes, it works in the adrenal glands, it works in the cancer cells, and this is why it adds benefit when it's used on top of the androgen deprivation therapy injections. Abiraterone is taken once a day. It comes in 2 tablet sizes. One is a 250, the other is a 500 milligram tablet. Most of the patients in Ontario at the moment probably take the 250 tablets, and they take 4 per day, and they take that on an empty stomach. They also take either prednisone or a drug called dexamethasone, and this is done amongst others to minimize some of the side effects. And the most common side effects that we see with abiraterone are a tendency to develop high blood pressure. Some men might have swelling of the ankles. We also have to check on the potassium levels. Hyperkalemia is a condition where the potassium levels are going low, which increases the risk of having, for instance, a irregular heartbeat. And then around 10% of patients might have issues with their liver when they take this medication. This is the reason why at the beginning, typically, we do blood tests every 2 weeks, because many of these side effects really happen in the first couple of months. And once patients are beyond the 3-month mark, it's very unlikely to have any additional new side effects. Then another group of medications are called androgen receptor blockers. So they don't interfere with the production of male hormones, but they can block the activity of male hormones. And we, in essence, have 3 medications at the moment. We have a drug called apalutamide, a drug called darolutamide, and a drug called enzalutamide. And again, I have put it here in alphabetical order because we really assume that these drugs are equivalent when it comes to the benefit patients get for treating their prostate cancers. These are tablets that are taken on a daily basis in the case of darolutamide twice a day. And darolutamide needs to be taken with food, whereas the other medications can be taken with or without food. All of these medications can increase the blood pressure. They are associated with fatigue. There's a little bit of higher risk of falls, in particular when it comes to apalutamide and enzalutamide. And if you have falls, then you also have a certain risk of having fractures. One of the unique side effects of apalutamide and enzalutamide are that they have a certain risk of inducing seizures. In patients that never had a seizure during their lifetime, that don't take any other medications that could increase your seizures, the risk is relatively low. It's 0.5% or potentially even lower. But unfortunately, when you use these medications a lot, you see patients from time to time that will have seizures. And then something that is relatively unique to apalutamide is that around 1 out of 4 patients might have a skin rash at some point that often can be easily treated with some ointments. And we have to monitor how their thyroid gland is working, because some patients might develop a condition where they don't produce enough thyroid hormone. These are medications that are used as tablets, can be taken at home, really don't have a lot of serious side effects. And this is why they are often the most common. They're usually the first-line treatment for most men with advanced prostate cancer. As I mentioned a few times already, we don't really have a lot of information to compare these medications. And we also don't have any tests we could run to really predict which medication might be the best for a given patient. So I think it often is more about finding the medication that has the least risk of side effects in a given patient. And we really assume that they work very similarly in patients. But we also know that if you, for instance, start treatment with abiraterone, it's often not very helpful to use all the other drugs or some of the other drugs afterwards, because these medications are cross-resistant. So when the cancer cells become resistant to one drug, they're often resistant to the other drug as well. And at least in my practice, and this is also driven by having access to clinical studies, I rather usually recommend to go on a clinical study as opposed to using, for instance, abiraterone followed by enzalutamide. But this is quite different from practice to practice. And for instance, in the United States, often patients are switched from one drug to the other, whereas in Canada, I think overall we do this less so, also to an extent related to some funding restrictions. Now, another big group of medications are chemotherapy drugs, and we use, in essence, 2 drugs, docetaxel and cabazitaxel, and amongst the 2, docetaxel is more commonly used. And I know that patients usually don't like the word chemotherapy, but these are drugs that are very helpful. They can contain the cancer, at least for a certain period of time. They can be helpful in patients that have, for instance, pain. And we know that despite the side effects related to chemotherapy, that how patients feel, how much energy they have, whether they can have more or less a normal lifestyle, the chances are better when they're on chemotherapy as opposed to just taking the cancer its course. And what these both medications do is that they interfere with what we call microtubules. Microtubules are like strings in a cell, and they help to move certain molecules from one end to the cell to the other end. And these processes are in particular important when cells are dividing very rapidly, and cancer cells are doing that. So this explains somehow why these medications can kill relatively specifically cancer cells, including prostate cancer cells that divide very rapidly. And here you have a slide that lists some of the side effects that one can see when patients are undergoing docetaxel and chemotherapy. And the reason why I like the slide is also this. In blue, you see the side effects that are reported by the patients, and in brown, you see the side effects that are reported by physicians. So that just shows that we as physicians often do not truly get a full picture of the side effects that patients go through when they get chemotherapy. Now, when you go through the list of side effects here, there's definitely also some side effects listed that have nothing to do with chemotherapy. For instance, hot flashes. They definitely have more to do with the hormone therapy that is usually done together with chemotherapy, and there's not the side effects from docetaxel and chemotherapy. But when I saw this slide, I also started to get more interested in some side effects that I'd rarely see myself, which I just didn't ask patients. For instance, change in taste sense. And we know that docetaxel can actually change the taste buds quite a bit. Which often explains why patients might start to lose weight, because they're just eating has no longer, they don't get the same drive to eat, because everything tastes in different ways. The good thing is that these side effects are typically transient. Some of them might take a little bit longer to recover, but most patients will have a almost complete recovery from most side effects. And this slide here I put up just to show you that chemotherapy drugs are different, or at least these two chemotherapy drugs, docetaxel and cabazitaxel, when it comes to using them in sequence. I mentioned before that I typically would not recommend, for instance, to use abiraterone followed by enzalutamide or enzalutamide followed by abiraterone. But we often use docetaxel first, and then we use cabazitaxel chemotherapy as a secondary option. And the reason why this might work in this case is that one of the ways cancer cells can become resistant to docetaxel is that they have pumps that can pump the drug outside of the cancer cells. And these pumps are very active when it comes to the docetaxel molecule, but cabazitaxel is different. This cannot be so easily pumped out of the cell. So this might explain why even when you had chemotherapy with docetaxel, patients still have a fair chance to have a good response to cabazitaxel. Another drug that works in a completely different way is radium-223. This is some kind of internal version of radiation therapy. And radium, as you can see here in the periodic table, is in the same column as calcium, behaves a bit like calcium. So when you inject radium into the bloodstream, it travels to areas in the bones where the bone is what we call remodeling, where the bone is changing, where there's a buildup of new bone and there's destruction of all the bone. And the version of radium that we use for treating prostate cancer patients, 223, this is a radioactive version. This is a relatively powerful type of radioactivity that can kill cancer cells in close proximity. And the radiation that emanates from radium-223 can cross around 10 cells. So it works very localized. That also means that it really kills the cancer cells relatively preferentially, and it doesn't really damage some of the other cells in the bone marrow, because the bone marrow is the place where the body produces blood cells, including red blood cells, for transporting oxygen in the body, or platelets are important to stop bleeding or prevent bleeds from happening. Overall, radium-223 is well tolerated. It can bring down the blood counts a little bit. That is called condition called myelosuppression, but not to the same extent as sometimes chemotherapy can do. A small amount of the radium-223 doesn't travel to the bones, but is actually secreted into the bowels. And this might explain why some patients might feel a little bit nauseous or might have a little bit more bowel activity than without the radium-223. But these are typically very mild side effects. And radium-223 probably is the best tolerated medication that we can use in prostate cancer therapy. But it has two disadvantages. One is that typically the PSA does not come down, and this is unique to this medication. It doesn't mean that if the PSA doesn't come down, that patients don't have a benefit, but physicians and patients alike are so fixed to see the PSA going down when the treatment is working that I had to get used to that, and I think patients have to be aware of that as well before they start ready to free treatment. And then the second disadvantage is that this is a medication that is injected intravenously, but as opposed to chemotherapy that goes to all parts of the body, it only goes primarily to the bones, and it would not help in patients that, for instance, have spread to the lungs or to the liver, or patients that have very large lymph nodes affected by prostate cancer. In the next few slides, I would like to discuss a few new treatments that are just on the verge of becoming available. For instance, olaparib is a drug that just was made available to Canadians through an access program. It's already Health Canada approved. And then I will speak about another drug called 177 lutetium PSMA 617, a complicated name. I'm sure that the drug will have another name when it actually becomes available in Canada. But I'm also sure that many of you have heard about this. And then I will speak a little bit about the immunotherapy as well. So why are we interested in drugs such as olaparib? This has to do with the fact that we have learned to treat patients better over the last 10 to 20 years, but we also have learned a lot about really what makes up a prostate cancer cell. And what we found out is that patients that have metastatic prostate cancer, and this would be a little bit the same as what I mentioned at the beginning, advanced prostate cancer. So patients with advanced prostate cancer have around a 10% chance of having genetic defects in their germline. And so these are genetic defects that are in all cells in a patient's body that affect genes that are important to maintain the integrity of the genetic information, to repair defects to the genetic information. And day in, day out, there's always genetic defects that have happened. And these are genes that not only affect the risk of having prostate cancer, in particular the BRCA2 and BRCA1 genes. BRCA stands for breast cancer. So these are genes that increase the risk of having breast cancer, having prostate cancer, having ovarian cancer, having pancreatic cancer. And when it's in germline, that means that patients could have actually could pass this on to their children, or they might have actually gotten it from their parents. So if we find out that patients have some of these defects, sometimes we also start some investigations into the families to find out whether there's other family members that could be at risk. So again, 10% of patients have defects in these genes in germline, but we also know that in 10%, in an additional 10% of patients, these defects are not in germline, so they can't be passed on to the children, but they just happen in the cancer cells. So overall, around 20% of patients have defects that affect genes that deal with a DNA repair. And why is this important? We have a new type of medication called PARP inhibitor. PARP is an enzyme that is important to repair defects of the DNA double helix. And if you impair this enzyme, then a small defect becomes a big defect, which often means that this double helix starts to break apart. And these are defects that are not so easy to repair, and they are repaired through a process called homologous recombination. And why is that important? So all these genes I mentioned before, the BRCA1 gene, the BRCA2 genes, these are genes that help cells to repair double-strand breaks. So when you use this drug and you create double-strand breaks, and this happens in a cancer cells that can't repair double-strand breaks, this cancer cell will at some point have so many genetic defects that it will simply start to die off. Whereas the normal cells in a patient's body has still the possibility, has all the tools to actually repair these defects. That means that this is a relatively selective way of killing cancer cells of this specific type without incurring a lot of side effects in patients. And olaparib and a few other drugs that are in clinical development are actually quite well tolerated medications. We have now some approved for olaparib, and this medication has shown in a large trial that it can improve the survival of patients that already had treatment before with, for instance, abiraterone and enzalutamide, or some of the patients also had treatment with docetaxel. I call it a chemotherapy drug. In terms of side effects, it's somehow in between intravenous chemotherapy, such as docetaxel and cabazitaxel, and maybe some of the hormone medications, such as abiraterone and enzalutamide. It can bring down the blood counts a little bit, but not to the same extent as a chemotherapy does. Some patients might feel a little bit nauseous, and either patients sometimes complain about soft stools or diarrhea, or some patients become constipated. But overall, these are medications that allow patients to go on with their life as close to normal as possible. Now, olaparib is Health Canada approved. It's not yet funded through OHIP, but at the beginning of this week, the company that produces the medication has opened a program that will make it easier for many patients to get access to this medication that otherwise, unfortunately, comes in at a cost of around $10,000 per month. And as you can see, there are other drugs in development as well. Rucaparib is fairly advanced, but I do not think that the company will file it with Health Canada anytime soon, if at all. And the other drug, niraparib, might actually become available for Canadians within the next couple of years as well. All pending the results of some of the studies that are close to be reported. Now, I spoke about PSA at the beginning, and another PS molecule is PSMA, which stands for prostate-specific membrane antigen. This is a molecule that is expressed on many cancer cells at the surface, and it can be used in two different ways. There are molecules that can be designed that have two arms. One arm can recognize this PSA molecule at the surface of the cancer cells. And then there's another arm that allows to bind a radioactive molecule to the PSMA11 molecule that you can see here on this slide. And when you use what we call a tracer, when you use this radioactive isotope called gallium-68, then you can use this tool to create PSMA PET scans. And I'm sure that many of you have heard about PSMA PET scans. PSMA PET scans is some of the new way of scanning patients with prostate cancer. You see a conventional bone scan of one of my patients on the left side, and you barely can see, maybe here you can see a spot that is suspicious for a metastasis, maybe here, and maybe something here. But then when you see the PSMA PET scan of the same patient, you see many of these spots here in yellow. Now, it's normal to that the kidneys, for instance, show up. This PSMA is also produced in the kidneys. It's normal to have some uptake in the salivary glands, and it's also normal to have an uptake in the bladder. But all the spots otherwise, these spots here, these are all spots with cancer. So this is a far more sensitive way to visualize where cancer cells are. Another way to use to make use of the PSMA molecule is that you create drugs where you have part of the drug that binds to the PSMA molecule, and then you again have another part that can bind some radioactive medication. In this case here, for instance, something called lutetium-177. Gallium is good for PSMA PET scans, but it would not be very useful for treating cancer patients. But the lutetium can do that. And you see here, and this was the image of the year 2018 of the Journal of the Society of Nuclear Medicine and Molecular Imaging. You can see here patients that had a PSMA PET scan done before they got this treatment, and everything that is red are areas where there's cancer cells. And then you see images done with a PSMA PET scan after the treatment was done. Some patients have multiple treatments. You can see that it's often almost a black and white phenomenon. And you can see here, for instance, here are patients where the liver is heavily affected, and you can't actually see the liver in the background because everything is red here. But here you can see again the normal liver after a few treatments. And this has created a lot of interest in using this medication. And unfortunately, what you see here are really patients that have a really marked response that you don't see in all patients. And only time will tell, and hopefully by the end of this year, we'll have some definite proof that this medication not only creates such striking scan images, as you can see here, but really also translates into benefit for patients. This is a medication that is relatively well tolerated. Patients can feel a bit nauseous at the beginning. Patients can develop dry eyes and a dry mouth. This PSMA molecule is also expressed in the glands that produce saliva and in the glands that produce the eye fluid. But in my experience, we were part of this study that hopefully will prove that this medication is having a benefit. In my experience, I was surprised actually how well tolerated it was. So there's no doubt that PSMA PET scans are more commonly used. At the moment, we have access issues. For instance, in Ontario, you can only do that as part of a registry study. And otherwise, at the moment, patients still might need to pay out of pocket if they really would like to have a PSMA PET scan. And that can be done, for instance, in Montreal. But there are also some question marks. When you have a methodology that becomes more sensitive, that raises questions whether we should then also adjust our treatments accordingly. And at the moment, we don't really know whether doing more PSMA PET scans really improves the way how we can help patients to live better and to live longer. And at the moment, I really support to use these methodologies as often as possible, but primarily within clinical trials. And to briefly show you some slides about immunotherapy. Immunotherapy, unfortunately, has not really panned out in prostate cancer as much as it has changed the way how we treat certain skin cancers or, for instance, lung cancer. What we know is that there are always cells of the defense system of the body mixed up with prostate cancer cells, but they are inactivated by molecules that are listed here and coded in red. And what we use these days are molecules that can break the communication between these molecules on the surface of the cancer cells with the surface of the T cells. These are cells that can kill cancer cells, and we can activate these cancer cells. And again, this results in stunning responses, for instance, in patients with melanomas, a special type of skin cancer. But in prostate cancer, it just hasn't really pinned out that much. There were two drugs in particular already tested in large trials, and both drugs actually did not really show a benefit. And probably the reason is that the genetic setup of prostate cancer cells is so different from melanoma cancer cells. And we assume that only maybe 5 to 10% of patients really have a setup that would make them good candidates for these treatments. And we really need better tools to identify which patients might be good candidates for these type of treatments. On top of it, I mean, these treatments have definitely side effects as well, and some of these side effects can be quite significant. So the last thing this is really the last slide I want to show you is about COVID-19. And there's no doubt that COVID-19 has had an impact on how we approach prostate cancer treatment. I think it's important to know that what we call hormone therapy, all these Lupron, Eligard, and so injections, then drugs such as abiraterone and zoldomide and radium-223, I consider as being safe, and I actually have not changed my practice about these drugs. Where I'm more selective is really using chemotherapy, not because we know that patients that are on chemotherapy have a higher risk of contracting COVID-19 or might not do so well, but we are concerned that this might not be a good combination. So chemotherapy, I really only use these days if I don't have any alternatives that I consider as being equivalent. And overall, there's no indication from the few things we know, and there's still a lot to learn, that prostate cancer patients would do worse than men of the same age when it comes to COVID-19. And really the risk factor of most of my patients is simply that they belong to an age group that has a high risk of having a severe course of COVID-19. There's even some theories that being on hormone therapy might actually be helpful to minimize the risk of contracting COVID-19 and to have a more mitigated approach if you're on hormone therapy. And this has to do with the fact that the COVID-19 virus that you can see here has to latch on cells so that it can be integrated and do its deadly job. And the molecule that is important for latching of the virus onto the cells is a molecule called ACE2. And once the virus is bound to ACE2, then it has to be processed in a certain way, and certain things of the surface of the virus have to be clipped away. And this can be done by a molecule called TMPRSS2, which is in yellow here. And we know that in men that are on hormone therapy, there's less of this TMPRSS2 molecule around. And that might be the reason why some people believe that prostate cancer patients might even be protected to a certain extent. This is controversial and definitely doesn't replace vaccination. And this is really my main message here. There's no reason that men with prostate cancer should not get the vaccination. I'm very much for vaccination. I really recommend it to all of my patients. And unless they have any other health issues, prostate cancer patients should be treated in the same way as somebody would be treated of the same age group. So this brings me to my last slide. I hope I could show you that prostate cancer is a condition that we can manage at least for years, let's put it this way. We have multiple tools that can help to make patients feel better and make patients live longer. There's quite a few new drugs that are in development that might become available in the next 5 to 10 years. And really, the best choice of treatment in a given patient at a given time, or how treatments are used one after the other, is highly individualized and really is a discussion. It should be decided in discussion between the patient and the treating oncologist. And it's not always so that more treatments are better. And there's also in each patient, unfortunately, a time where maybe stopping treatment is a consideration. But being diagnosed with prostate cancer and deciding not to do anything at all, I think is not really a good alternative. And I really feel strongly that in Canada, patients with prostate cancer that has spread to other parts of the body should be offered hormone therapy. And most men are fit enough to get at least either abiraterone or enzalutamide or one of these hormonal tablets. With chemotherapy, definitely it's a little bit a different thing. That might be for some men too much to consider chemotherapy. So this brings me to the end, and I am now really open to answer any questions you might have. One thing that came up, and I think Keith sent me in an email, this question about something called bipolar androgen therapy. So this is somehow doing the complete opposite of what I told you to do now. So these are patients that would get these hormone shots, for instance, would get a Lupron shot. And then from time to time, they might get a high dose of testosterone. So this is somehow shaking a tree back and forth, is having very low testosterone levels and having very high testosterone levels. And there were definitely some studies done that show interesting results in the sense that in patients that no longer respond to hormone therapy, when you give them high doses of testosterone, you can somehow make the cells again susceptible to further hormone therapy. I think the problem with these studies is that these studies were done with men that were highly selected. And obviously one concern is that if you have a patient with widespread metastasis and you inject testosterone, this actually might make the patient very sick and the patient might have a lot of pain. This means that patients that will recruit for these studies are typically patients that would expect to do better than patients that would be excluded from these type of studies. And this is definitely not something that should be done outside of a clinical study. There's very few centers that actually run these type of studies. We'll see whether this really will pan out. This is an interesting, rationale for doing this type of studies. But again, my key message is that this should not be done outside of a clinical study and not it should be done through somebody who does not have experience with these type of treatments. And then the second question I got is, how do we deal with heart conditions? And I mentioned before that, unfortunately, hormone therapy comes at a certain risk of increasing the risk of having heart issues. And this can happen in patients that never had heart issues before, but the risk is even more pronounced in men that already have heart conditions before they start the treatments. And prostate cancer patients typically under 60s, 70s, 80s, and it's quite common to have heart conditions from the get-go when they diagnose with prostate cancer. And the specific question was that this was a patient that has a low heartbeat, and this has been corrected with a pacemaker. So that's not something that should be concerned when it comes to choice of prostate cancer treatments. And then this is a patient that sometimes have some extra heartbeats, which I also do not think should be a real concern. And third condition that the same patient has is he has a condition called atrial fibrillation. Atrial fibrillation is a heartbeat that is irregular. The heart has a biological pacemaker, and if this pacemaker is no longer working properly or overrun by pacemakers that can be hiding in the heart muscle, then the heartbeat becomes irregular, and some patients have sometimes very high heart rates, and they can change with lower heart rates. And the risk of having episodes of atrial fibrillation where the heartbeat goes really high is definitely a little bit higher in men that get prostate cancer medications. And the question was specific about whether patients should get abiraterone or whether they should get something called enzalutamide, palutamide, or darolutamide. These drugs have never been formally tested against each other, but based on what we know from the studies, I would assume that abiraterone is probably a little bit at a higher risk of resulting in complications in patients with heart conditions. And this is why in some patients might then decide not to use abiraterone, rather use a drug such as enzalutamide. But I have plenty of patients where abiraterone overall is the better choice. They might have some atrial fibrillation, might have other heart conditions. And I think often it's not just one comorbidity that will decide whether one drug is preferred over the other. I think really is about taking everything into consideration.
He would like to know when you think these second generation drugs should be started. Immediately on signs of rising PSA that is non-metastatic but castrate resistant? If not, why not? Also your opinion on what new imaging such as PSMA PET will do to staging. That is, METs will be found much easier than with bone CT scans. Does this mean starting such second generation drugs that much sooner?
Okay, so this is a relatively loaded questions, and there's actually there's a lot of things where I can't give you a definite answer. I can just tell you how I think about that. So the first thing is that non-metastatic castration-resistant prostate cancer is a relatively rare condition where patients are on hormone treatment. They have a rising PSA, and they get usually a bone scan done, and they get CT scans done that cover everything from the chest down to the pelvis. And despite the rising PSA, that means that there are cancer cells around. We can't really detect where the cancer cells are. And there were 3 studies done over the last few years that have shown that in some of these patients, to use drugs such as apalutamide, enzalutamide, or darolutamide relatively early on can translate into a significant survival benefit in the order of probably a year or longer. Now, these are patients where we know that they have a higher risk of developing metastases that we can detect with conventional scans within usually 1 to 2 years. And these are patients where not only the PSA goes up, but it goes up at a certain pace. And what we use as a measure is what we call the doubling time. So how long it takes from, let's say, PSA going from 10 to go to 20. And if it takes less than 10 months for this to happen, these are patients that would be considered as being at high risk. And we assume that around 1/3 of patients with a rising PSA that are on hormone treatment and the scans are negative are amongst this group of high-risk patients. And in these patients, I typically recommend to start the treatment as soon as they qualify for this because of the doubling time, with a few exceptions. We know that men, and this is where age unfortunately matters a little bit, elderly men and men with a lot of other health issues, they might not really have a long-term benefit of treating them very aggressively from the get-go. So I think, again, it's not just about the prostate cancer, it's also about who you treat with prostate cancer. And I would say that in my practice, when I take the men that have a doubling time of less than 10 months, that in principle would be good candidates for the treatment, I might treat maybe 8 out of 10, but there might be 2 where I'm hesitant to do so. And the hesitancy has to do with the side effects. And I didn't really speak too much about that, but enzalutamide and apalutamide, more so than maybe darolutamide, are drugs that can not only induce fatigue, but men can also have a harder time to, for instance, concentrate when they have to do something. And their thought process might slow down. And the risk is definitely higher in elderly men than in younger gentlemen. And that can make for some elderly people such a difference that maybe it's really not justified to treat so early on. And the alternative to not treat is just be very careful and to follow on these patients, and then to consider starting a treatment when there's really signs of metastasis, and then again to have a discussion about what the best treatment option is. And once patients have metastasis, there are different treatments of other treatment options available that might be more appropriate for these patients. Now, the other question is that how does this change when you do PSA PET scans? And I can tell you that at Sunnybrook, we have GU rounds once a week, and we usually discuss between 5 and 10 cases. And more recently, I would say that probably 1/3 or even more than 1/3 of cases are patients that had a PSA PET scan done. And the reason why we discuss it during GU rounds is that we don't really have a lot of information to use the PSA PET scan information, because all these studies that were done as imaging studies to compare how the PSA PET scan is, for instance, how the PSA PET scan compares to a conventional scan. And we know that with PSA PET scans, we can see metastases before you can see them with conventional imaging. And unfortunately, we don't have a lot of studies that would inform us whether we also then should become more aggressive with the treatment. And eventually, I think this leads to some individualized decisions. So when I have patients with a PSMA PET scan that is positive, but the conventional scan is, for instance, negative, if I start them on a treatment and do maybe something that is a little bit more aggressive than I would do otherwise, I really discuss with the patient that they have to be aware that, yes, we can do it. We can get access to the medications, but there's no guarantee that it will have a long-term benefit. And these are sometimes difficult discussions from my end as well, because again, I would love to have more information. And I'm sure that within the next 5 to 10 years, imaging in prostate cancer will be probably largely the conventional imaging will be replaced by just doing PSA PET scans. In countries such as Australia, I hear that oncologists no longer do any conventional scans, they just do PSA PET scans.
The next question is, in addition to A to Z, what comes next? Where do advances in immunotherapy stand? And what is the likely time frame for their impact on prostate cancer? Also, could you share your thoughts on radioligand therapy?
Yeah. So when you develop drugs in prostate cancer, it depends on which stage you treat. So when you treat, for instance, localized prostate cancer, where patients usually live on average between 10 and 20 years, it takes a long, long while to do clinical trials, because the longer somebody, the better the process, the longer it takes to develop clinical trials. And when I moved into the prostate cancer field, in essence, we were treating patients that had a life expectancy of 1 to 2 years. And clinical trials often could be done within 5 years, and we had an answer after 5 years. Now, all the drugs that have been developed in later stages are now used in early stages, where again, the prognosis is better and it takes longer to have good information. So typically, for many trials, it's realistic that it takes 5 to 10 years before you have a final answer. And it takes another probably 5 to 10 years before this to develop the drug. Because it's not so that you have a good idea in a laboratory, you design a drug, and then you can use it in humans. It takes a lot of legwork that has been done before. Now, with respect to immunotherapy, I think unless we can solve the issue of really finding out which prostate cancer patient is a good patient for immunotherapy, I'm not sure whether this will become a commonly used treatment in the next 5 to 10 years. And the reason is that there's 2 ways to deal with that. First of all, if either you can identify patients that are good candidates, and then you just use the drugs in the patients that are really having a good chance to having a response. Or you try to design clinical studies where you convert the patient that might not have a good chance to respond to immunotherapy into a patient that will have a good response. And I think there's a lot of studies that actually try to do that. For instance, at the moment at our center, we have a study where patients get chemotherapy and at the same time they get one of these drugs that boost the immune system. And the hope is that these patients will do better. And this is something that we probably will know within the next 2 to 3 years or so. But immunotherapies are also designed in different ways. I showed you the more conventional way that you develop antibodies that interfere with the communication between the cancer cells and the cells of the immune system. There's now some designer molecules where you can have one arm of the molecule will bind to the immune cell and then will actually connect the immune cell to the cancer cell. And for instance, you can do that with the PSMA molecule. So you have a molecule that binds the PSMA molecule on the cancer surface. And another branch of the molecule will actually engage an immune cell to be in close proximity to the cancer cell. And these are drugs that are undergoing early development. There's one trial that is about to open that hopefully will give us an answer within the next 5 years or so, whether this is a viable approach or not. I think one of the issues with prostate cancer immunotherapy is that for reasons that we don't really understand very well, the risk of side effects, and unfortunately that also includes fatal side effects in prostate cancer patients when they are exposed to these type of agents, seems to be higher than, for instance, melanoma patients. And one of the differences, for instance, between melanoma patients and prostate cancer patients is that prostate cancer patients typically, when they would use this type of treatments, are in their 60s or maybe late 60s, 70s, sometimes the 80s, whereas melanoma patients are often quite younger, and that might just make a big difference. And the other thing, and this has to do a little bit with COVID-19, some of these designer molecules can actually make patients quite sick for 1 or 2 days, like having a really bad cold or so. And these are treatments that often need to be done in the hospital. And at the moment, we were planning actually to open one of the trials with one of these designer molecules. And at the moment, we just don't think it's feasible to do that, because we can't, run a trial where there's a high risk that patients might actually need to be admitted to the hospital, might even finish up in the intensive care unit for covering some of the side effects, because we need intensive care unit beds for other patients at the moment, obviously. And obviously, the higher the risk of side effects, the more difficult it will be to use this type of agents at some point, not just in Toronto, but maybe also in Sudbury or in more remote places. I think the easier a drug is, the more patients in Canada will benefit from it.
The next question is, in your opinion, what is the optimal sequencing of the various hormonal therapies?
I think as oncologists, and when I go to conference, we speak a lot about sequencing, and I'm actually more and more of the opinion that the sequencing might actually not matter that much. I think by far more important is that, I mentioned in my presentation that we have 10 treatment options that can prolong the life of patients. And most patients probably use 2 or 3 of them. And I think it's more important to offer as many options as possible to patients, opposed to having a certain strategy of using drug A followed by drug B followed by drug C. Having said this, I think there's also practical considerations. First of all, taking one of these hormone tablets, abiraterone and enzalutamide, for instance, is just so much more convenient for patients and actually works as good, if not better, than chemotherapy, that I usually start patients on one of these hormone tablets. Once they become resistant, I usually recommend to use something different, either chemotherapy that works in a different way, or radiation-free that works in a different way, or sometimes we have clinical studies that offer a drug that works completely differently, just to increase the chance to having better responses. But you know that if you treat along the same lines, the return gets smaller and smaller. To give you one example, there was a study done in BC where they treated 100 patients first with abiraterone, and then they treated them with enzalutamide. And the other 100 patients, they were treated with enzalutamide first and then abiraterone. When you start with enzalutamide and you use abiraterone, the response rate to abiraterone is around 5%. When you use abiraterone as a first-line treatment, the response rate is, depending on the study, between 60 and 80%. So I rather prefer to use one drug for as long as it's safe to do so, but then to switch to something else. And this is also why I didn't want to show any slides about certain sequences or so. It really depends on who your oncologist is. I think sometimes it's more important to be familiar with the drugs and to know how to deal with the side effects, and to help patients to stay on the medication for as long as possible than anything else, and then actually not to miss the right time point to switch to something else. But again, switching for me means usually trying to use something completely different.
Are there any adjuvants that can be used in conjunction with hormonal therapies to increase their efficacy?
By hormone therapy, I'm not sure whether this means Lupron injections or so. I'm not aware of anything that really could boost, the benefit from Lupron injections. I know that, and I think this was one of the questions that Keith had in one of the emails that sent me in the past, whether, for instance, it would be helpful to use a drug called metformin, which is a diabetes drug, or for instance, cholesterol-lowering drug, statins. For instance, Crestor is one of these drugs that is commonly used in Canada. I think the difficulty of knowing whether these drugs really have a significant impact is that many patients already use one or the other drug. I think metformin is very commonly used, with, unfortunately, many of my patients have a tendency to have diabetes. Elderly patients tend to have a high cholesterol and take some cholesterol-lowering drugs. So many of my patients are already on these medications. And I personally rather think that if they have a benefit, it's probably relatively marginal. And there's nothing that really would, provide some extra year or some really massive benefit. So if there's a benefit, it might just be very, very, might be incremental, if at all. I think it's more important to not forget about minimizing the risk of having side effects of these medications. In particular, I showed you the slide about the hormone therapy, and for instance, having a high risk of developing complications of the bones, osteoporosis, for instance. This is something that we can easily minimize the risk for, or patients with, for instance, heart condition, that maybe the oncologist has to speak with the cardiologist from time to time as well, and just optimizing the chances that the patient will not have another heart attack when they start on the hormone treatment.
The next question is, can you compare the relative efficacy of hormonal therapies with cabazitaxel?
Again, by hormonal therapy, I assume that this means, Lupron, Eligard, and then some of these injections. The problem is that I consider Lupron, Eligard to be life-prolonging therapies, but these drugs were developed at the time where it was not found to be ethically correct to actually randomize patients to treat them or not to treat them, in particular not when patients have metastatic prostate cancer. So we know that they work in the majority of patients. We know that they can keep the cancer under control, typically even when patients have metastasis for 18 months to 24 months on average. So they're highly efficacious. And they're used at the earlier stage where it's probably more easy to have an impact than when you use chemotherapy that you give at the later stage. So there's no data that really could compare these two treatment modalities. One thing that has changed over the last 5 to 6 years, though, is that we have found a new niche for using a chemotherapy. And this is a little bit to, as opposed to what I told you before. Typically in prostate cancer, we don't really mix things too much. But we found out that for patients that never had treatment for prostate cancer and have already metastatic prostate cancer, when they are treated with hormone injections plus chemotherapy, they can actually do quite a bit better. Whether, at the end of the day, it's primarily driven by the hormone injection, and maybe the hormone injection make up a big part of the benefit, but it is really the combination that is important. The problem, though, is that chemotherapy is not ideal treatment for many patients, in particular elderly patients. And unfortunately, the risk of being diagnosed with prostate cancer when it already has spread increases with age. So if you're between 80 and 90, the chances are that when you are diagnosed with prostate cancer, it has spread in maybe 1/3 of patients. When you're younger, then the chances are that it's probably less than 10%. So this is why then some of these hormone tablets are important. With the same trick you can do with chemotherapy, you sometimes can also do, you cannot, not only sometimes, you can do with the hormone tablets as well. And many patients these days will not just get the hormone injections, they will get the hormone injections plus the abiraterone tablets or enzalutamide tablets very early on. But again, I can't stress this more, that this is not the right way to go for all patients. There are patients with so many other health issues that you might be more concerned about the side effects of what you do than the benefit you can get out of it. And it is a different thing to use a medication that has a certain risk of side effects when you really run out of other treatment options, as opposed to when you still have a very good tool. And I think just doing the hormone injections on their own, again, this is a medication that works in an approach that works in 90% or more than 90% of patients, and usually can keep the cancer under control for up to 2 years or so.
Do you have any suggestions regarding ways to ameliorate the side effects of the hormone therapies?
I don't have any magic bullets. I rarely start hormone treatment myself, so I don't really have a lot of discussions with our patients about this. I think there's side effects that we can help more so than others. I have a special interest, for instance, in bone health. So I would assume that the large majority of my patients, they will take something for their bones, either calcium tablets or vitamin D tablets. Sometimes they take some other medications. I have become a little bit more aggressive recently. Maybe aggressive is not the right word, but I have become more proactive when it comes to cardiac health. Because this is something that we somehow knew that this was an issue for hormone therapy, but we really didn't do a lot against it. And I think with more and more data now coming out, we realize this is really something that we have to tackle better. There's also side effects where it's sometimes difficult to help, for instance, hot flashes. There are different medications that have been tested that can reduce the number of hot flashes, or at least can somehow reduce the severity of the hot flashes. But many of these medications come with their own set of side effects. And at the end of the day, when you treat the side effect of one medication with another medication that introduces another side effect, then it becomes a little bit unfortunate situation for a patient. So I think there's things we can help and there's things we can't help. Something that I recently started to develop an interest in is something called sarcopenia. Sarcopenia is, in essence, the loss of muscle strength and muscle mass when you're on hormone treatment. And I recommend patients with prostate cancer to Google what is the Arnold Schwarzenegger when he was in his prime, and to Google him now. There are some pictures of him with the upper body that can see actually how much his body has changed. And we unfortunately don't have any tablets that could easily help to maintain strength. It really comes down to being as active as possible. Now, if you have a let's say really a bad case scenario, if you have an 85-year-old gentleman who's diagnosed with prostate cancer, who has a heart condition, who had a stroke, who's using a walker to move around, I can't tell a patient like this to go for a run or to go for a walk 30 minutes each day or so. But if patients are fit enough, it's really important to maintain a certain level of fitness. And the difference might be that with hormone therapy, it's probably important to do more sessions and shorter sessions as opposed to trying to go to the point where you're completely exhausted and then you might pay the price the next day or so. So I usually recommend my patients to stay as active as they can be, but maybe to portion it a little bit. And if they want to shovel the snow, that they might actually do it in the morning and in the afternoon, as opposed to just doing everything in the morning and then they are not able to do anything for the rest of the day.
After high-dose brachytherapy and 23 fractions of high-dose radiation, how can I determine if my 5 to 6 METs have been eradicated, regardless of current PSA?
So I'm not sure whether I get the full picture of where Mike is in at the moment. It depends sometimes on where the metastases are. So if patients, for instance, have metastases to the bones, it's quite rare that you can see a complete resolution of the metastasis. If you have let's say, a single metastasis in the lung, and I have a few patients like this, and patients get high doses of radiation therapy, you see a scar, but you also can see that the tumor actually just shrinks away. And I have now one patient, for instance, that had one single lung metastasis done, I think it's now more than 5 years, and he no longer uses hormone therapy and his PSA stays low. And I assume that in his case, this was probably just the only site where the cancer was. Now, if you want to follow patients, aside from PSA, you can do scans. Bone scans are not great to follow patients. They're good to detect bone metastasis, but it's quite difficult to interpret bone scans when it comes to knowing whether patients are doing better or worse. The same is a little bit true for CT scans as well. Now then, many patients or many physicians might be tempted to order a PSMA PET scan if you can access it. If patients have very small metastases that you can barely see on a conventional scan, you can do a PSMA PET scan. But my question then would be that if you know that you still have something around, would you really change your treatment? And in many situations, actually, we probably would not recommend to change the treatment. So when it comes to being more aggressive with imaging, one of the rules I apply usually is when I do a scan, do I really and find something, a change? Do I really think that it will change how I treat my patients? And if I really do a scan just for the sake of doing the scan, I don't think this is a good use of resources. But again, the most sensitive ways of knowing where cancer cells are is to use a PSMA PET scan. And unfortunately, sometimes patients then also have bad surprises in that they were told with conventional scans they maybe have 1 or 2 spots, and when they do PSMA PET scan, they might finish up with having 50 spots or so. And I think patients have to be aware of this as well. It can be a little bit both. It can go both ways.
There have been some studies looking at the use of palutamide in active surveillance. Can you comment?
I'm not aware of the study, so from this point of view, I'm not the right person to answer this. I think this is a situation where you have to balance the benefit and the negative aspect of doing that. Really, the philosophy of active surveillance, and this has actually been developed here at Sunnybrook. Dr. Klotz was one of the people that really developed the concept, is that you decide not to treat the cancer and just to keep a close eye on it, and only to treat when there is any change that the cancer is getting worse, and still having a exceedingly high chance to actually cure patients from the cancer. And we know that from the data here from Sunnybrook, but also from other studies from other places, that patients on active surveillance actually do really, really well. And when you then use a drug such as apalutamide, first of all, patients might have side effects from apalutamide. And when you use apalutamide at a very early stage, you might no longer be able to use it at a later stage. So I'm not aware of any data that would convince me that this should actually be done. Again, I think it somehow undermines the concept of active surveillance.
Is there such a thing as slow metastatic progression versus fast metastatic progression?
I showed you this picture of this many people. That was one of our first slides about these many different people that are walking the street. So each cancer is different. And sometimes cancer is going through phases where things are not changing so much. And usually towards the end, the changes can be more rapidly. So there are definitely patients where, where something pops up, and sometimes they might have radiation therapy, and then it takes a few years and something else pops up in another place, you do radiation therapy, and in between nothing happens. And on the other hand, sometimes you have patients where we do the scans, we have the impression they only have 1 or 2 spots, we try to treat them. And in our case, in our center, often this, if it's about treating metastasis, would be primarily with radiation therapy. And then they come back 3 or 6 months after the treatment, and they have 20 new spots or so. I think what we do not know at the we do not know at the moment how we can identify these patients. And if you're a patient that, let's say, 75, has a few other health issues, and has maybe just 1 spot in the bones, and otherwise no pain and really no symptoms related to this, if you would know that maybe it will take another 5 years before another spot will show up, you might just ignore your prostate cancer, and you might not have the side effects from prostate cancer treatment. But at the moment, we just don't know that. And on the other hand, if you would have any factors that we could use that predict patients that do not do well, these are the patients that I myself would like to treat more aggressively, patients that maybe are good candidates for clinical studies. But in prostate cancer, we just, aside from the Gleason score and the burden of prostate cancer, we don't really have a lot of factors that really would help us to subgroup patients. And this is something that definitely will change, because we now do more and more studies where we not just treat every patient that is interested in the trial, we only treat patients with certain types of prostate cancer based on the genetic makeup.
Is darolutamide available in Ontario? Is anyone taking Regulox, the new oral LHRH drug?
Okay, so darolutamide is Health Canada approved for patients with non-metastatic castration-resistant prostate cancer. This is thus far the only indication, and this is a relatively rare stage of prostate cancer, at least in my practice. And it's not yet funded through OHIP, but the company has an access program, and if patients fulfill the criteria for the access program, then they can get this medication for free. With respect to relugolix, this is not yet Health Canada approved, so it's only approved in the United States. At the moment, you can't really access it. And my concern about relugolix is that I assume that the price tag will be such that we might not get easy funding for that. There is an alternative to relugolix, and relugolix has not been compared to the alternative. It's a drug called Firmagon. Firmagon is one of these hormone injections that works in a slightly different way than for instance, Lupron or Eligard, and might have some of the same benefits that relugolix has as well. And Firmagon is actually available in Canada, and usually is paid through the usual health plans. Now, I want to also make the point, though, that I think the final word about whether relugolix or whether Firmagon are really better than the other treatments is still depending on some studies that probably will report within the next 1 or 2 years. And thus far, we know that these drugs might have a benefit when it comes to maybe side effects such as heart attacks or so, and maybe the pace at which they can drive down the testosterone reading and maintain low testosterone readings. But whether this really translates into patients doing better, we simply do not know yet. And that will take a few more years before we have some more definite answer about that.
Can you explain again the cancer that makes PSA continuing to rise but does not show up in scans, including PSMA PET scans?
So I think there's actually two questions in this question. The first question is that are there cancers that we can't detect with PSMA PET scans? Yes, there are cancers that we can't see, and this can be sometimes in a patient where you do a PSMA PET scan, you don't see anything at all, or sometimes you have a patient where you see some spots that are PSMA PET scan positive and other spots are negative. And the tool can only be as good as somehow the biology dictates. So a PSMA PET scan can only work when the cancer cells expresses the PSMA molecule at the surface. And if the cancer cells are not doing that, then the PSMA PET scan cannot work, you can't see it. And we know that aggressive types of prostate cancer have a tendency to express less PSMA and thus become somehow invisible for PSMA PET scans. And we also know that when you analyze cells that circulate in the bloodstream, and most prostate cancer patients that have metastases have cells that are in the bloodstream, we know that some of these cells express PSMA and others are not doing that. Now, the other question is that are there cancers that don't produce PSA or that do not produce PSA? Yes, there are cancer cells that produce very much amounts of PSA or no PSA at all. And these are typically, again, very aggressive types of prostate cancer. And it is something that sometimes happens when patients have multiple lines of treatments, because each time you use a treatment, and the cancer becomes resistant, the cancer cells usually become more aggressive as well. And there are sometimes patients where the PSA no longer really is useful and doesn't really change a lot. But when you do the scans, we see that there's big changes going on. This is why you can monitor patients with PSA alone to a certain extent, but typically from time to time, it's wise to do scans as well. And maybe one last comment I want to make again about this issue of PSMA PET scan and conventional CT scans. If you can't see cancer on conventional CT scans, it's quite unlikely that patients actually will have symptoms. So with PSMA PET scan, you sometimes can see very small tumor deposits, but patients are not expected to have any symptoms from that. Whereas if you see a 2-3 centimeter lesion in a bone, in a bone scan or in a CT scan, then it is quite likely that patients either they will have symptoms relatively soon or will develop symptoms in the short future. Whereas with PSMA PET scan, we can pick up some places where, at least in some patients, it might take months, if not sometimes a couple of years before they really might develop symptoms, even when they would continue with the same treatment.
Can radium-223 be administered twice over a 3-year period?
So radium-223 has been studied in essence only in one big study, and this study was designed in a way that patients that had chemotherapy of docetaxel, or patients that were not considered fit for docetaxel or refused to have docetaxel and had cancer primarily confined to the bones and had bone pain, and they were treated with either radium-223 for 6 treatments, 4 weeks apart, so for a 6-month period of time, or they were treated with other means. And this study somehow dictates what the approval is for radium-223 and how we use it. So at the moment, outside of a clinical study, patients will get radium-223 for 6 treatments over a span of 6 months. There was a study where we were participants as well, where some patients got a high dose of radium-223 and other patients got a prolonged course of radium-223 beyond 6 cycles. And none of these maneuvers, the higher dose or the longer treatment period, really did result in a significant benefit for patients. This is not a definite study as such. This is not a really large study, but this really has, I think, tamed the enthusiasm to change the way how we use radium-223 at the moment. But there are clinical studies going on where patients will get re-exposed to radium-223 after a while. And we sometimes do that, for instance, with docetaxel chemotherapy as well. I would usually not recommend to do that with drugs such as abiraterone and enzalutamide. So it might actually work under certain circumstances, but just funding-wise, and I mean, radium-223, we speak about the drug that costs around $35,000 for 6 months. I don't see it happening that at any point soon we will be able to use it, and we also really don't have the data to support such an approach at the moment.
If darolutamide and Regulux are not approved yet in Ontario, is there any way of getting these drugs now? Does anyone know what the process would be?
Again, darolutamide is approved for a specific situation in prostate cancer, and it's Health Canada approved, and it can be accessed through an access program. And actually, the hurdles to get into this program are not that high. Other than this, I don't think that you can get it other than you buy it out of pocket. And I don't really know what actually this would mean in terms of costs. With respect to relugolix, I personally would not prescribe that here in Canada until we have Health Canada approval. This is primarily for legal reasons. And then the other argument from my end would also be that, again, we have something that is relugolix-like. I mean, it's not a tablet, but it's an injection, it's Firmagon. So if somebody really wants to use a LHRH antagonist opposed to LHRH agonist, I think we already have some kind of way to do that. How this would be that if you would go to the United States and buy the medication in the pharmacy in the United States, probably that would work out. But again, I do not know what the list price would be for this drug. And I suspect that this will be probably the same, might be in the same range as some of the hormonal treatments that we use, abiraterone and enzalutamide, which if you would need to pay out of pocket in Ontario at the moment, probably costs around $3,000.
It's good to say that olaparib, etc., improves survival, but by how much? What does a man get for the cost and quality of life he gives up?
Okay, I think quality of life is very difficult to really, put the number to it, because quality of life is something very, very individual, and we have some tools how we measure quality of life, and that allows us to compare two different treatment options, but it doesn't really tell a lot how an individual patient really feels, whether he feels that much better or not. In terms of survival benefit, if you choose the right patients for using olaparib, then you see that compared to using the best option you have otherwise, the differential in terms of survival is around 4 to 5 months or so, I would say. And these are patients that are often running out of other treatment options, so it can really add some extra time. Now, this is information from clinical studies, and we know that when we treat patients outside of studies, usually the benefit becomes a little bit smaller, because study patients are usually a bit more healthy and they are a little bit pre-selected. So again, maybe it's not even right to give a number or so, but I would say that olaparib can provide survival benefit in the order of a few months. And in terms of quality of life, I can give you one example on my experience with olaparib. At the moment, we have a study where patients that have metastatic castration-resistant prostate cancer, so they start the first type of treatment for their castration-resistant prostate cancer. And these patients are either treated with abiraterone alone or abiraterone plus a placebo, or they get abiraterone plus olaparib. And when I opened the study, I was somehow sure that after a month or two, I would know who actually gets olaparib or not. Because, I mean, again, side effects, feeling a little bit nauseous, maybe having a bit of diarrhea or constipation, and some laboratory changes as well. But truth be told, I know of none of my patients where they actually get the placebo or not. And I use this as an argument to say that olaparib overall is actually a fairly well-tolerated medication. And the better the medication is tolerated, the less it should have an impact on the quality of life. And sometimes it's not, unfortunately, about improving the quality of life, which is often very difficult, but just maintaining a certain level of life and a certain quality of life for longer than without the treatment might be very helpful. And generally speaking, I think, when I oversee now a little bit more than 15 years of having worked in the prostate cancer field, I'm still disappointed that we can't really make patients live that much longer. But what I've seen is that my patients these days can have a more normal life for by far longer periods of time than it was in the past. And I tell that patients that come to me and when we have the discussions that are more towards the end of a patient's life. In the past, I often have patients that really were sick from the prostate cancer for 6 to 12 months. And I see that less and less. I think really the phase where patients might become more tired or they might have pain and need to take strong pain medications, this has become shorter and shorter. And I think this is really due to these medications that we have.
How is radium-223 administered? Is it a pill or a needle?
So I didn't mention that. So this is a injection that is done into one of the veins. It's a relatively small volume. So if patients have treatment with us here, I see them in the clinic, they get blood tests done, they will be approved, and they need a venous access. That is probably the most time-consuming part of the treatment. Once the venous access is established, the drug can be administered in less than 5 minutes.
Is the PSMA 617 lutetium 177 PRRT available anywhere in Canada?
In Canada, no, outside of clinical studies. Worldwide, there are countries such as Germany, for instance, that have completely different legislation when it comes to using these type of drugs. So in Germany, you can get the 177 lutetium PSMA 617 treatment, and you can come from Canada, but you have to travel there, which is an issue at the moment, COVID-19, obviously. And it costs, what I heard, around $20,000 per treatment. And I haven't actually sent any of my patients. I think this is why we open trials here, that we often have an alternative here that patients don't have to travel. And I also, just from a more philosophical point of view, really do not like the idea that patients have to pay for the treatment that at some point at least should be offered by the health system. There are other places where you can get PSMA treatments done as well. Australia has a little bit more liberal access than we have. I had once a patient who went back to Iran, and apparently in Iran you can get it for by far the lower price than in Germany. So there are some places where you can do that, but I think for practical considerations, this is unfortunately not an option for most patients that I see in my clinic. And at the moment, we don't have, unfortunately, any trial with a PSMA compound, but we will open 2 studies, and actually one study probably a little bit later. We'll have 3 studies towards the middle of this year, so that many of the patients that I see, if they are at some point candidates, hopefully can get access to this medication. And then maybe one last comment is that I can't emphasize that more. I have seen a few things coming with high price, and then it hasn't really pinned out. I really would like to see the data first before I would send patients for this treatment. I might be a bit more conservative about this than maybe some of my colleagues. But this is really based on experience with other medications. I think with this compound, I think it's quite likely that the study will be positive. But I have seen other things that looked so promising in smaller trials, and then when we did the definite trial, actually, it did not really provide a significant benefit for patients.
In cases where prostate cancer has metastasized in the lung, how beneficial can immunotherapy be in such situations?
There's certain sites of the body, such as, for instance, the liver, where usually metastases come with relatively limited prognosis, and this just has to do with the fact that whatever treatments we try often do not work as good in the liver than in other places. And in the lung, I personally have the impression there's 2 types of patients. There's some patients that do really well and often don't need treatment for sometimes months, if not years. And there's other patients that actually don't do so well. And So this just tells you that when you do for instance, a clinical study and have a few patients with lung metastasis in the study, it's very hard to make a conclusion about whether a certain drug specifically works well in the lung or not. I think there's no reason to assume that immunotherapy would work better in lung than in other organs. I think the more fundamental question is that whether immunotherapy actually works in a given patient or not. And I think this is what we do not understand. Typically, when immunotherapy works, it works throughout the body. And there are some studies that might indicate that maybe immunotherapy might have a harder time to be beneficial when it comes to patients with bone metastases. But these are, early studies, and I think we don't have the data to really argue about this. And at the end of the day, what we really lack is that we don't really know who these patients are that have a good chance to benefit from immunotherapy. There are some molecular changes that we assume that actually increase the chances. But even when you select these patients according to molecular changes, there's quite a few patients that will not have a response at all. And I think the problem is sometimes that we focus too much on one thing, because when you have a cancer that has certain features that would indicate that maybe this is a cancer cell that is susceptible to immunotherapy, this cancer cell might have a lot of other features that actually make it a very aggressive cancer cell otherwise. And I think we just need a more integrated approach where we just not look at one or two characteristics, but we can integrate that and then come up with a treatment plan that tries to address all the changes in the cancer cells in a more efficient way.
Is genomics testing of prostate cancer cells helpful in making treatment decisions? Foundation medicine test called Foundation 1 CDX test is referring to that.
There's no trial that will prove that it really changes the outcome of patients. And I think eventually it's really about what I tell you now is more about my personal take on this. I think the problem with all these tests is that these tests were developed primarily with, for instance, lung cancer in mind, with colon cancer in mind, maybe a bit of breast cancer in mind as well. And prostate cancer is just genetically, molecularly differently wired than many of these cancers. And this is not just my experience, actually. You'll hear that in discussion with colleagues, that when we do the conventional tests, often it doesn't really show anything that we can use as a way to change the treatment strategy. Because the changes that are important for lung cancer are just not playing a role in prostate cancer, or at least not to the same extent. I rarely send patients for genetic testing, particularly again when they have to pay out of pocket, because I warn them that it's quite unlikely that it will help me to treat them differently. And on the other hand, we do now more testing as part of clinical studies, but then it's usually really just for one specific question, and we don't then need to do hundreds of genes that are tested. We just focus on maybe one or two genes that are of interest to a clinical study. So before you do something, that's the same is true with scans and with blood tests or so. I think you have to question yourself whether it really has a fair chance to make a difference or not. And to be honest, this is not really my decision to say what is a fair chance or not. I think eventually this is the patient who will decide. If you have a 5% chance of finding something, that might be good enough for some patients to do the test. But for other patients, that might actually be an incentive not to do the test, because simply the chances are so low that it most likely will not have an impact.
What do you think about combination treatments? For example, Lupron plus enzalutamide administered at the same time.
So we do that actually quite commonly these days. For instance, patients with metastatic castration-sensitive prostate cancer, they will start on, for instance, Lupron. And then often I would see them within the next few weeks. And then at some point, you might start them on enzalutamide, and we continue both treatments as long as they help. So we do that actually quite commonly. I'm not sure whether the question was that whether you can do it around the same time, so that you take enzalutamide tablets around the same time when you go hormone injection. This can completely run in parallel, and we don't expect any worse outcome when you actually do these treatments at the same time. There are studies done at the moment for a certain stage of prostate cancer where actually enzalutamide is now compared to Lupron, for instance. And then this is compared in a third comparison to the combination treatment. So patients get either 2 medications or they get one of the 2. And the results of these studies probably will be available within the next 2 to 3.
What is your experience with osteoporosis in patients on ADT? How do your patients respond to low-dose denosumab, Prolia?
This is something that I have been interested in since quite a few years. And I don't think that you can prevent osteoporosis in all patients, but if patients develop osteoporosis under my helm, I actually feel guilty that this happens. I think there's good ways to prevent this from happening in most patients. And I think it really starts with the fact that whenever somebody goes on hormone treatment, I personally think, and again, this is my approach, and not everybody might agree, that they should get a bone densitometry done, which just tells me how good their bone health is to start with. And if patients have a normal bone density, I usually recommend to use vitamin D, and I use also calcium supplements unless patients have a high calcium intake through their diet. And that is primarily driven by, for instance, eating regularly dairy product, cheese, milk, yogurt, or so. If patients have something called low bone mass or osteopenia, which is some kind of early version of osteoporosis, I personally usually send them to our osteoporosis clinic. And the physician that sees most of my patients agrees with me that these patients need more than just vitamin D and calcium. They usually will get tablets, something called bisphosphonates. These are tablets that you take often once a month or once a week. And they minimize the risk that low bone mass will become osteoporosis. And I do that as long as I don't have any reason to use a medication called Xgeva. The medication, the generator of the medication is denosumab, and Xgeva is the brand that is used for prostate cancer patients. And Xgeva, when you use it according to textbook, has 2 benefits. First of all, it is helpful to minimize the risk of having complications from bone metastasis, such as, for instance, pain or fractures, or needing radiation therapy for painful bone metastasis. And since it's dosed so high, it also will minimize the risk of developing osteoporosis. You mentioned another drug called Prolia. Prolia is the same medication also called denosumab, but it's the osteoporosis prevention brand of denosumab. And Prolia is given at 60 milligrams every 6 months, whereas denosumab is often given at 120 milligrams every month. So you dose patients with advanced prostate cancer more than 10 times higher with the same medication than just for preventing osteoporosis from happening. Obviously, this comes with a certain risk of side effects, and there's a complication that I usually warn my patients whereby these drugs, they strengthen the bones in general, but they can weaken the jawbone, something called osteonecrosis of the jawbone. And the risk of this to happen is around 1% per patient per year. So it's not really high, but it becomes a little bit, it's cumulative. So over time, the risk actually goes up. And patients that, for instance, have issues with their teeth, that either have gum issues or that have wobbly teeth, or they have infections or need any, invasive dental procedures, they are at a high risk to develop this complication. So the bottom line is that this is something where we can really make a difference by preventing things. And we know this is a side effect from what we do in terms of treating patients. And on the other hand, this is one of the easily preventable side effects from androgen deprivation therapy.
When moving on to 2nd-generation drugs, how is it determined whether Xtandi or ytiga with Lupron would be the best to start with?
The first thing is that we don't really have a lot of information whether ytiga would be better than Xtandi or vice versa. And I consider these drugs as equivalent when it comes to the benefit that patients get out of it. And I would say that probably 2/3 of patients are good candidates for both medications. And 1/3 of patients are probably better candidates for one or the other medication, but that has more to do with maybe the expected side effects and maybe some of the other health issues that patients might have. But in my practice, I don't prescribe one over the other because I have the impression one is better than the other. I think it's more about fitting the right medication to the right patient in the right situation.
Very specific to his personal situation. So his two entries, I'll read everything out. He was diagnosed with metastatic prostate cancer 2 years ago. He went through 6 cycles of docetaxel 1 year ago. Enzalutamide failed after 2.5 months. He's been recommended to start radium-223 every 4 weeks for 6 cycles. Should he also be on Xgeva? He's also been on Lupron for almost 2 years, and he has bone metastasis throughout his body.
Okay, so based on the information provided, again, this is my practice, and I don't claim that the other people might actually think slightly different about this. Based on this, I assume that Nicholas has metastatic castration-resistant prostate cancer with bone metastasis, and I typically consider starting patients on Xgeva when this is the case, unless they have any reasons that you should not do it. And sometimes it's dental issues, sometimes it can also be issues with the kidney function. And then on top of it, we know that radium-223 is actually medication that is not great for bone health. And if I don't have patients on denosumab, once I start radium-223, this is another incentive to actually start them on denosumab. And I would highly recommend actually to consider doing that. Now, having said this, this is the way I practice this aspect of prostate cancer care. There are other physicians that rarely use any of these medications, and they have other reasons why they don't do that. We know that denosumab or the Xgeva and all these medications that act on the bones, and with the exception of radium-223, they do not really have an impact on how long patients live. Whereas radium-223, we know actually can make patients live longer and better. So this is the reason why some physicians are not really using this medication on a regular basis. But in my practice, unless there's any hard reason not to do this medication, or patients do not want to start these medications, most of my patients at this point would actually be started on Xgeva or already be on Xgeva.
Can you comment on personalized medicine in prostate cancer?
I think in prostate cancer, everything takes a little bit longer. I sometimes why my colleagues that see breast cancer patients. In breast cancer, we speak about different types of breast cancer since probably already 20 to 25 years. And I think in prostate cancer, we just start this discussion now. And I think it has to do with some of the medications that we are trying to develop. And I think the olaparib drug that I introduced to you is the first time we actually practice what most people would claim is personalized medicine. So we analyze either a blood sample or a tumor sample of patients. And if they have certain genetic changes, then we might consider them candidates for olaparib. And we also know that these cancers that have a good chance of a response to olaparib behave different than the ordinary prostate cancer. But this is really just the first time we do that. And there's no other drugs coming where when we do the clinical studies, we can't put everybody on the study. We actually have to do first some genetic testing to find out whether patients have a certain type of prostate cancer before we will put them on a study and try to find out whether drugs that are specifically designed for these type of situations are really helpful in the long run.
Can you comment on the utility of using estradiol as an additional back to maintain bone health?
I'm not sure whether I understood the medication that he's referring to.
Estradiol. Estradiol. As an add back to maintain bone health.
So estradiol is a female hormone, and there were studies done with a drug called toremifene, which is some kind of similar molecule as estradiol. And the problem with these medications often is that they have an increased risk of, for instance, inducing blood clots. This is why they're not really popular, but they actually are probably as helpful as some of the medications that we use now. But at the moment, we primarily use a drug called denosumab, which slows down cells in the bones that eat up bone material so that bone can be remodeled. And there's another group of medication called bisphosphonates that either can be used as tablets or given as an intravenous infusion. And they damage this osteoclast, these cells that actually can degrade bones. but we rarely, or at least not as a standard of care, we use female hormone types of treatments for this. There is some interest to use again female hormones, as it has been tested in 1960s, as I referred to in my presentation. But now it's done in different ways. So the problem with female hormone tablets is that when you take them as tablets, they are processed in the liver, and that changes some of the factors that the liver is secreting, and that has to do with the increased risk of having blood clots. But when you can give the same medications in a different way, and often it's done on patches, that you have some patches that you stick on your in your skin, then you might have the benefit of the female hormones without the risk of having the blood clots. And female hormones in the past, when we didn't have all these treatment options that we have now, we actually used sometimes female hormones in the past as a prostate cancer treatment. And I think there's a little bit of a renewal of the enthusiasm to use this type of approaches. There's one big study that is done in UK at the moment that probably will give some results within the next 3 to 5 years, I would assume. And if this study is positive, that actually can really then could rejuvenate the interest in female hormones. But for the time being, I can tell you that I never prescribed female hormones with the purpose of maintaining bone health. I think we have good other tools that have a reasonable side effect profile that are very well documented, and that we can use on a day-to-day basis.
He sent another message saying he's talking about estradiol patches or gel, not oral. Does that make a difference?
I think the patches, again, the patches have the benefit that they probably don't have the same risk of side effects as some of the tablets. But it's, at the moment, we really don't have as much information and documentation of the benefit of using estradiol patches as we have for many of the other treatments that we use. And at the moment, I think this is something that I would be open to test as part of a clinical study. But I do not think that this should be widely used. And if it's used, then I think the prescribing physician really needs to have a good discussion with patients about the pros and cons.
In case there is an increase of PSA after prostatectomy from undetectable to 0.1 to 0.2, would you recommend hormone therapy or radiation first, or both at the same time?
Okay. So this is a situation where I'm usually not involved in directly. So this would be either a radiation oncologist or a surgeon that probably would decide about these things. So typically what would happen in patients like this these days is that they potentially would have a PSMA PET scan to find out whether it's just the prostate cancer growing back in the place where everything started, or whether patients have metastasis, and that might then have a little bit of an impact on the treatment. If you have metastasis, then the role of androgen deprivation therapy usually becomes more important. And on the other hand, if we, for instance, or even conventional scans, if we can show that the PSA is going up and then there's some regrowth of prostate cancer in prostate area, patients after prostatectomy typically would be offered a course of radiation therapy. Whether radiation therapy is done with hormone treatment for a limited period of time or without, this is something that has not yet been completely settled and depends on the risk profile. And I think I don't have enough information to really comment on this.
Is it advantageous to do a germline test to see which treatment is best for the type of cancer?
So the germline test is done. We actually have a program since recently here where you can offer germline testing to patients with metastatic prostate cancer. And what we do is that we take a blood sample, and then what is analyzed is the genetic makeup of some of the white blood cells in the bloodstream. So that doesn't tell me, that does not tell me that much about the genetic makeup of prostate cancer cells. On the other hand, we know that if, for instance, I spoke about this BRCA2 mutation. So if a patient has a germline BRCA2 mutation, it's almost a given that the cancer cells will have the same, will actually obviously they will have the same defect as well, with that in germline means that each single cell in the body will have the same defect, but on top of it, the cancer cells, they have 2 copies of each gene, and the cancer cells usually can kick out the second healthy copy, and then actually it becomes a true cancerous cell. So germline testing can give us some hints, and for instance, using the drugs as olaparib, this can be really that stepping stone to actually be considered for olaparib, but not for any of the other studies, for any of the other medications. We know that unfortunately, the most common genetic changes we see in prostate cancer cells, we don't really have medications for to treat patients specifically, and we try to develop these type of tools in the years to come. So the reason why I recommend at the moment to consider genetic testing, in particular in patients where there's a certain red flag raised because of family history, when other members of the family have prostate cancer, or for instance also breast cancer or ovarian cancer, is twofold. First of all, if I can, for instance, detect a patient with BRCA2 germline changes, I might early on consider him for treatment with olaparib, and just do then the extra testing to actually get access to the drug. On top of it, since around 10% of my patients have some of these defects that can also increase the risk of other family members having a high risk of having prostate cancer or ovarian cancer or breast cancer, we usually would send these patients for genetic counseling. And this is something that I think we just start to roll out here in Canada. I think that's probably the same for most countries across the globe. There's certain places where they might be a little bit ahead of us. The issue is that we don't really have enough genetic counselors at the moment to really roll that out, that we can offer it to really everybody. But I think that in the not so distant future, probably everybody with cancer in general will have some kind of genetic testing. And then we'll have, depending on what they find, patients will have some follow-up with a genetic counselor. The problem is that we are really just at the beginning of really understanding these type of things. And then the other question is that if you do a test and you find something, but you don't really know how to help the patient, then the question is that should you really do the test or not? For some patients, it's actually, these are often not patients. For some people, it might be helpful to know it, even when they have to accept that maybe there's no remedy for it, at least in a short term. But for other patients, or for other, not patients, for other individuals, it might actually be very difficult to deal with the fact that they have some genetic changes that might increase the risk of having certain types of cancer. And then to live with it, knowing that there's no easy way to potentially prevent that from happening.
I thought we were done, but there's one last question, and I won't take any questions after this. What is the best treatment for patients with neuroendocrine tumors, but PSA stays undetectable?
I think this is a type of prostate cancer that we really have to learn to do better. If I have a patient with neuroendocrine prostate cancer, I typically would try to get some testing done whether they are candidates for a PARP inhibitor like olaparib. And if that is the case, then this would probably be my preferred choice. More conventionally, we treat neuroendocrine prostate cancer patients primarily with chemotherapy, more so than with hormonal agents. And we don't typically use docetaxel and cabazitaxel. So we often use other drugs, such as a drug called carboplatin or cisplatin, and sometimes we combine it with a medication called etoposide. So in very broad terms, it's probably a condition where we rather use chemotherapy than anything else. And we would use a little bit unconventional types of chemotherapy as opposed to the conventional docetaxel and cabazitaxel.
Thank you so much, Dr. Emmenegger. Very educational and essential details. We definitely appreciate your time, especially as you've had a long work day. Sincere thanks. Roberto says, thank you very much, Dr. Emmenegger. This was a very educational and instructional presentation. So that ends our questions for this evening. Before I end the session, I just want to announce that our next Awareness Night event will be on Zoom again. It's on the 31st of March It's Wednesday and it's at 7 p.m. Dr. Gerald Morton, who's a radiation oncologist at Sunnybrook, will be speaking. So look out for an email that announces that. We'll send you an email to save the date, and then we'll send you an email with the link to register for the evening. So thanks everyone for your questions, and thank you for attending. And most of all, thank you, Dr. Emmenegger, for staying the extra half hour or so. And I'm sure everyone enjoyed your presentation, a lot of information that you gave. And like you said, you know some of them, so you'll probably be seeing them in your clinic or on your online follow-up meetings with them. So on behalf of everyone at PCS Toronto and our audience, Dr. Emmenegger, Dankeschön, guten Nacht, and auf Wiedersehen.
Gern geschehen. Thanks so much, and be safe. And we still have to think about COVID-19 as well. Stay safe.